So thanks for the introduction, and I know a lot of faces in here, so it's great to have our public health family here, and then the greater ETSU community as well. I apologize if I take some sips of water. I've had a bit of a little tickle in my throat all week, so hopefully that does not bother us. So as Phyllis mentioned, this is based on the work that we've done in Nicaragua, and this is a study abroad course that the College of Public Health teaches in the summer, and it's called Interprofessional Perspectives on Global Health. And there's a few people in here that plan on taking the course and a few people who I will acknowledge later who have helped put together these data and help with the project. So what I'm planning to talk about today, and feel free to ask questions whenever you have them or make comments if you have them. I enjoy it when we have more of a discussion and less of a lecture, so although, if you don't feel like talking, that's fine too. So we'll go over HPV, the human papillomavirus, cervical cancer, and the role of HPV in cervical cancer. We'll look at the global burden of disease with cervical cancer. And last month, if you were here, Kate Baker and Donna Nolan talked about some women's health issues. So we have cervical cancer in the U.S. and Tennessee kind of covered from that. So I'm going to focus on the big 30,000-foot view of it today. We'll look at Nicaragua, kind of what the country is all about, and specifically the cervical cancer burden there. And then I'll share with you the case study that we did in this town of Nicaragua, and of course some acknowledgments at the end. So it is Sex Week, so we are talking about sexually transmitted infections, and I'd like to start there because that'll kind of set the tone for the rest of what we're talking about. So the human papillomavirus is a group of more than 150 viruses. So it's very, very common. It's one of the most common sexually transmitted infections worldwide. There are about 40 HPV types that can affect the genital and reproductive areas. It's the most common viral infection in the reproductive tract. So pretty much if you are sexually active, men and women can be infected with HPV. It's extremely common. Most people will be infected at some point in their lives. Most people will be infected more than once at some point in their lives. So as I mentioned, there's about 150 different strains of this virus. And I'll talk to you about a few types that we really need to be worried about when it relates to cervical cancer in just a minute. But it is sexually transmitted. So this means vaginal, anal, or oral sex, or even just skin-to-skin contact. So it can be easily transmitted. That's why there's such a burden of HPV, and that's why it's the most common viral infection globally in the reproductive tract. So HPV infections can clear themselves up without any intervention. Most of the time you can clear this infection within about 2 years of your initial infection. Some say between 80% and 90% of HPV infections can be cleared with your immune system. However, that varies from person to person. And really what we're most worried about is that 10 to 20% that don't clear themselves. And those are the problematic high-risk HPV types that are associated with cancers. So HPV and cervical cancer, there are about 13 HPV types that we found to be associated with cervical cancer. 2 of those types are the types we're most worried about. That's type 16 and 18. So those 2 types are the high-risk types of cervical cancer, and what we see most often in the U.S. that would cause cervical cancers. We'll see a picture in a little bit of globally where HPV, what types it is, and where they are located throughout the world. Cervical cancer is almost all the time caused by HPV, so it is a cancer caused by a sexually acquired infection. So for those of you guys that are interested in infectious disease and chronic disease, this would be one of those areas that you could look into working in. As I mentioned, nearly all cervical cancer cases are attributed to HPV infection. So roughly 80 to 90% of the cases are attributed to HPV infection. There's also recently been much more evidence linking HPV with oropharyngeal cancer, so that's cancers of the oral cavity and the pharynx, so head and neck cancers, cancers of the anus, vulva, vagina, and penis. So as you can see, these are all linking kind of HPV with and the sexually transmitted infection with cancer. So keeping that in mind, when we talk in epidemiology, we want to know if something's causal or not. So for those of you guys studying this or already working in epidemiology. Cervical cancer, we have found over and over with studies that HPV is associated with cervical cancer. And so we can kind of make a statement that if HPV is present, or if cervical cancer is present, HPV probably is also present or was at some point. The evidence linking HPV to these other types of cancers is still being built right now. So keep watching the literature for that, and we'll see as we build more causal linkages. Just keeping that in mind. So I'm not sure, I know we had a little bit of trouble seeing slides last week, or a couple weeks ago, but this is a picture of HPV and cancer in the United States. So the purple line is showing what is attributable to HPV. On the bottom here, we have listed the different types of cancers, and it's separated by male on the left and female on the right. So if we're really looking here, we want to look at cervical cancer, and you see the purple line is what's attributable to HPV, so 80 to 90%. The blue area are those cancers that are not attributable to HPV. So this area right here is male cancers, and that's of the oropharynx. So we see that a lot more of those are attributable to HPV. These are the average number of cases per year that are attributed to HPV. So keeping that in mind that this is an average, and this is also US data, US specific data. So this is not global data, and I'll talk about reasons why we don't have global data in a minute.
Dr. Quinn, can you talk a little bit about the blue area? What are you seeing in terms of what might be the causal variables that are emerging in that?
Right, okay, great question. So, so the blue areas, depending on which type of cancer, would be different things that would be risk factors for those blue areas. So those blue areas on the graph are things that are not attributed to HPV. So for, say, oropharyngeal cancers, smoking might be a big risk factor that would be contributed to, well, really any type of tobacco use. So with cervical cancer, they really don't know what's causing cervical cancers that's not HPV associated, but there are other risk factors like smoking is associated with cervical cancer, mainly just the dysplasia that would occur in creating abnormal cells for cancer growth. So we don't know exactly why every single type of cancer is caused and what is associated with that. So the blue area is a little bit variable depending on what type of cancer it is, but there are risk factors associated for each of these cancers. Age being one of the biggest risk factors, so cancer is a lot more common as you get older, and that can be accounting for some of that. Yep.
So, for men and women, head and neck cancer, more head and neck cancer cases are attributable to HPV than are attributable to tobacco products?
So for oropharyngeal cancers, yes. So that would be like cancers of the soft palate or cancers of the tongue and things like that. So, and what we're seeing, as I mentioned earlier, I guess, with HPV, it can be transmitted through oral sex. So we're seeing a big linkage there with HPV-associated cancers and oropharyngeal cancers. So, and these data are recent data from the CDC, so we're seeing that kind of trend rising. Now, lung cancer and smoking or tobacco use would obviously be a different kind of situation. All right, great questions. So we've got, this is the map I was telling you all about. I've got little arrows in here. Pretty much every time I have a map, I'm going to point you to where Nicaragua is, which is a little hard to find, but I had a lot of fun drawing arrows. So I want you all to, because this is difficult to see, so red is bad. I'm going to take Donna Nolan's topic here, and then white is no data, so then the lightest shade is good. So here we can see that these are HPV and cervical cancer. So we're looking at incidence of cervical cancer, which are our colors here. And then our little circles are telling us the prevalence of HPV in each country. And then the black circles are telling us what type of HPV that is. So for example, we'll start with us. So North America, we've got about overall prevalence of HPV in healthy women is 13.8%. And the most prevalent HPV types are 16, which makes up 3.5% of HPV cases. So 3.5 of that, 13.8 is type 16, and about 1% is type 18. Types 53, 52, and 39 are the other 3 that we are seeing, and those are all around 1% or under 1%. So in Central America, we have an overall prevalence of 20.5% HPV in healthy women, with about 4% of those being HPV type 16 and about 2% being type 31 and 2% being type 18. So thinking statistically about this, we know that in North America where we're getting our statistics, right? So we know that we can feel pretty comfortable with that number. In Central and South America, it's most likely data from the Pan American Health Organization, which is a subset of the World Health Organization, which should be really good quality data, but are we capturing all of the little areas in each community? And that's what we'll look at in Nueva Vida and see that in San Diego. So basically what we can see here is we have some hot pockets or hot zones of HPV infection or cervical cancers. About 85% of the burden of death for cervical cancer occurs in low-income countries, and you can see that here with the incidence rates. And although we're seeing that HPV infections, only about 4% of them were type 16 in Central America, HPV 16 and 18 account for about 70% of those cervical cancers. So keeping that in mind, we've got a really high amount. And you'll hear different numbers. That's because all the data are being reported from different areas. So keeping in mind that sometimes it's a bit of an average. So when we think about HPV, we want to understand how we're progressing from normal tissues into cancer, correct? So these tissues over here are normal cervical tissues. You've got exposure here to HPV, and then you move towards productive infection, precursor lesion, and then invasive lesions. And you can see how the cells change. So in your first block here, that's CIN1 or intracervical neoplasia, cervical intraepithelial neoplasia, 1, and then 2 and 3 along the top. So for those of you guys in the back and watching, I'm trying to explain the chart. So you can see that the cells are changing here. You have a few abnormal cells. So that might show up in a pap smear as abnormal cells. But you can go clear the infection, so you can see the line that goes backwards, back into a normal cervix. So if your body is able to clear the infection within that 2-year period, like I mentioned, you might go back into a normal cervix. If it's not able to clear that infection, which meaning likely you have high-risk types of HPV, you move on to a precursor lesion. So your disease progresses. Then you can see there are more abnormal cells, and then along to an invasive lesion, which would be cervical cancer. Most of the time, when we see this type of abnormal cells that occur, we can kind of figure it out here and then prevent progression to cervical cancer. That's the hope. So that's what we'll talk about a little bit more in just a second. So now that we understand HPV, how it's associated with cervical cancer, and how an infection progresses from a normal cervix on through to invasive cervical cancer, I want to give you guys a little bit more detail on cervical cancer globally. So it's the 4th most common cancer in women worldwide, so it's the 4th most commonly diagnosed cancer in women worldwide. That means basically new cases of cervical cancer, which would be our incidence measure, and then current cases, which would be our prevalence measure. We have about 266,000 deaths of cervical cancer that occur annually across the world. And so those are deaths that are reported due to cervical cancer specifically. Most cancers in the cervix start in the lining of the cervix, which is the exocervix, and there are 2 main types. So squamous cell carcinomas, which occur in the exocervix, which is about 80 to 90% of those cases, and then adenocarcinomas, which is about 10 to 20%. So in case anybody is not familiar with the female reproductive system, we'll look at it really quickly. So in order to continue talking about this, I felt like we might want to know what the cervix is and where it's located. So it's on the lower end of the womb or the uterus. It's about 2 to 4 centimeters in length, and it's made of connective and muscle tissue. So the main functions are that it provides cervical mucosa to help transport sperm, and it protects the growing fetus. Sorry. And so you can see here the two different types of cells that I was talking about earlier. So squamous cells, which are in the exocervix, and then glandular cells, which is where an adenocarcinoma would occur. Signs and symptoms of cervical cancer. So in your early stages, so think back to where the disease was progressing. In the early stages, when you might be in CIN1 stage, you may be completely asymptomatic, wouldn't have any symptoms, there wouldn't be anything really going on. It's very slow progressing, so it takes quite a bit of time for you to notice any sort of symptoms. I keep switching slides, sorry y'all. But once you do see symptoms, sometimes there's vaginal discharge or abnormal vaginal bleeding or pain during intercourse. But again, hopefully you can prevent any of these symptoms with getting your annual screening or every 3-year screening, depending on your personal situation. So some of the risk factors associated with cervical cancer are early age of sexual initiation, so sex prior to the age of 18. Again, sexually transmitted infection that is associated with cervical cancer, so any sort of sexual risk factors would increase your risk for cervical cancer. A high number of sexual partners. So this kind of goes back to how prevalent HPV is worldwide, so if almost everybody has the opportunity to get HPV, then having a higher number of sex partners can increase your risk. However, even just having one sex partner can increase the risk because it is sexually transmitted and so prevalent. Race is also a risk factor, so we see a lot more cervical cancer cases in African American women and also Hispanic or Latino women. That, we're not sure if that's because of some sort of different types of HPV that are associated with those types of women, but most likely it's due to lack of access to pap smears and screening and treatment. Age is a risk factor, so most of the time we see cervical cancers between age 20 and about age 60. Often we don't see them until around age 35 or 40. So again, it's very slow progressing. So might have initially had an HPV infection at age 20, never symptomatic, and then didn't see an abnormal pap smear until age 30, didn't do anything about it, and were diagnosed at age 35. So that would be something that could be an option. Smoking is also a risk factor. Shameless plug, smoking is a risk factor for every type of cancer, so just don't do it if you can avoid it, or call the Quinn line. But smoking is a risk factor because, so when you're looking at the cells in the cervix, the dysplasia that I was talking about with the progression of the infection, smoking can disrupt those cells as well. So smoking is something that will also, if you have an HPV infection and you smoke, it adds kind of another risk factor to you, so it kind of exponentiates your risk. And then, of course, HPV infection type 16 and 18 mainly. Prevention. So lots and lots and lots and lots of ways to prevent cervical cancer. Of course, there are several that are going to be associated with avoiding those risk factors that I mentioned. So limiting the number of sex partners, delayed onset of sexual initiation, using condoms, of course. And using condoms will help prevent from lots of sexually transmitted infections and pregnancy, if that's not what you are looking for at the moment. Vaccination is also available for cervical cancer, well, for HPV, which will then prevent cervical cancer, and the pap smear test. So to talk a little bit about vaccinations, there are two different types of vaccinations available for HPV, and these two types have been a little bit difficult to get people to uptake, but we'll talk about what they are and who they are approved for. So the two types are Gardasil and Cervix. These are both 3-shot series, and they can be administered over a period of about 6 months. So Gardasil, which we can see over here on the left, is approved for both males and females. So that's great because we can vaccinate both males and females. So if it's associated with HPV infections, or if cancers that are caused by HPV infections, we can prevent them by vaccinating males and females. It's approved for ages 9 through 26 currently, and it's recommended that children are vaccinated about age 11 or 12. Why would that be important? Just to let you guys answer a question.
You want to get it before intercourse starts.
Correct. So you want to vaccinate those kids before they start having sexual intercourse. So otherwise, vaccine may not work, right? So
At age 11 and 12 coincides with usually the last well child check that child will have, so it's a good opportunity for providers to take advantage of the need for school vaccines at that 11 and 12-year-old well child visit.
right, perfect. So you have a kind of a convenient sample of kids already going to the doctor. So it's perfect time. Gardasil protects against 4 different types of HPV, so it's a quadrivalent vaccine. So it protects against types 16, 18, 6, and 11. So you probably remember from our lovely map that 18 and 16 were very prevalent, but we didn't see a lot of 6 and 11. It does protect against those types though. So 16 and 18 are your 2 that you really want to target. It does protect against genital warts, so those are type 6 and 11, lower risk types for males and females. And it protects against cervical, vulvar, vaginal, and anal cancers in females, and protects against anal cancers in males. The other vaccine that's available is Cervix. This is approved only for females. So if there was a test question and somebody asked you if Cervix was approved for males, you'd say no, because it's not. It's for ages 10 to 25, mainly recommended, so it's got a little bit of a tighter window than Gardasil. But again, you still want a vaccine between ages 11 and 12 for females. It protects against HPV type 16 and 18, so the high-risk types. Yeah?
I have a question about how long it will be effective and lifetime.
So these 2 vaccines haven't been around for that long. So currently, we assume it's lifetime protection, but we haven't had any longitudinal studies to show that one way or the other. So, but yes, it should just be the 3-shot series, 1 time. So 1 month, you get the initial shot, you wait a month, and then you proceed with the rest of them. But yes, it should be 1 time. Yeah.
How effective is it though if you don't have access after that first month of getting that vaccination? I mean, if you only have 1 in those series, how effective is it going to be long term?
Right, so that's a great question, and I'm not sure. Donna, do you know?
We were seeing some protection with 1 vaccine, but like you said, there's no studies to tell from a longitudinal standpoint whether or not just 1 injection is going to provide a vaccine or coverage for your lifetime.
And that's why the 3 are recommended. So, I mean, if you know somebody that's only received 1, definitely promote talking to their healthcare provider to see how they can catch up on their other 2 vaccines.
So that's a big problem.
Exactly.
It's a very big problem.
And I think a lot of our, vaccines in childhood, we think, oh, we just need to go the 1 time and get it done, or we'll go once when they're a baby and then again when they're 10 or something like that. And so this is one that definitely 3-shot series within a 6-month period is what is known currently. So this is showing, again, a very small picture, but this is a map showing HPV vaccine uptake. So dark blue, good, and no color, bad. And you can see Nicaragua has no color there. So whether or not that's because there's no data or because we actually don't have any vaccine uptake, not exactly sure. So we'll go into that just a little bit, in just a little bit. There are national programs in the countries listed over here to the left, and there are pilot programs going on in the countries over there to the right. Nicaragua is not listed in either of those areas. So in order to screen for cervical cancer, so we talked about prevention, and now we want to talk about if you couldn't prevent it. So if you weren't able to get a Gardasil or a Cervix shot, what would happen? How would you screen for this? So we love it when cancers have a screening test, because then we can hopefully catch early if we have better prognosis. So for cervical cancer, there's a screening test that's available. It's called the Pap smear. This has been around for years and years and years, and actually didn't have to go through a bunch of screening tests because it was so good that it would have been unethical to take it away at that point. So it is a screening test that should begin at age 21. These are the recommendations from the U.S. Preventative Services Task Force. if your individual situation is different, you should definitely talk to your healthcare provider, and the best bet is to talk to your healthcare provider about when you should be screened. A general population health statement would be cervical cancer screening should begin at age 21. Women between 21 and 29 should have a Pap test every 3 years if they are normal. If they are not normal, you need to have a Pap test more often than that. Women between the age of 30 and 65 should have a Pap test every 3 years, plus an HIV test, which is called co-testing, or an HPV test, sorry, which is called co-testing. And so you want to at least have that HPV co-test every 5 years is the recommendation. And women over the age of 65 who have had regular cervical cancer testing with normal results should not be tested for cervical cancer anymore. So, as I mentioned earlier, it's a very slow growing disease, so if you haven't seen anything by age 65, likely the disease is not progressing and you've cleared any sort of HPV that you had. So diagnosis and treatment. So if you are screened and you receive an abnormal Pap smear, you might be asked to come back again within 3 months or within 6 months to get another screening. At that point, if you are still have an abnormal Pap smear, you might go through a biopsy. So they might biopsy those cells and see what's going on. You might also have an endocervical curettage, which is basically a way of scooping out a part of the cervix to look at those cells. A colposcopy would be next, which is also another kind of diagnosis and treatment method. And then if we are progressing farther along with the disease progression, surgery, radiation, and chemotherapy are also options. But hopefully you kind of stopped earlier in this part and you don't progress into the bottom half of your options. Most often we can prevent cervical cancer from going into any of the latter treatment methods, at least in the US. So global incidence and mortality. So as I mentioned earlier, incidences are new cases, number of new cases over a population number. So we have about 528,000 new cases in 2012, so that's a prevalence estimate actually, sorry. And developing countries have a higher incidence. As I mentioned earlier, about 85% of those cases are occurring in developing countries. Our mortality is about 266,000 deaths in 2012. These numbers are from Global Can, which is the Global Cancer Stats information, and 2012 is the most recent year they have. And this accounts for about 7.5% of all female cancer deaths for cervical cancer. This graph shows global age standardized incidence and mortality rates. And so down here on the bottom, I know that's probably going to be very difficult for you all to see, but our blue line is the incidence and our red is the mortality. And at the bottom here, we have listed different countries. So we start over here on the left with Eastern Africa. And then Central America is in here. So you guys can see those graphs there. So our incidence is still quite high, but we have about half of those that are resulting in mortality from cervical cancer. Another nice arrow. Global cervical cancer mortality rate. So Nicaragua is a blue country, which is on the worst on your spectrum. So that's over 41.7 deaths per 100,000 people. So thinking back to the earlier map that we saw where the incidence rates were dark red, now we have the mortality rates, and the blue is the color that we want to look at. Those are the worst rates. So where we had high incidence rates, high number of new cases, we also see high numbers of mortality. So kind of the same hotbeds that we saw earlier. So nobody should really be dying from cervical cancer. It's extremely, extremely preventable, and that's one of the reasons why we did this project in Nicaragua. So as we can see these areas that are dark blue here, ideally you would not see anything that's dark blue on this map. So you would see almost everything looking like we do, because it should be able to be prevented. Mortality should be prevented based on the treatments we have available, the screening recommendations we have available, and the vaccination we have available. So Nicaragua, as you've seen with a lot of little arrows throughout this presentation, is located in Central America. Nicaragua has had a lot of different types of natural disasters occur. They've had a lot of civil unrest, they've had a civil war, they've had a lot of different countries come in and say, we're gonna help you, and then not really help you. Maybe you just gave a lot of money to bring in a new dictator or something like that. There's a lot of things that have gone on with Nicaragua, and the stability of the country has probably only been around for 25 or 30 years. So when you think about a healthcare system having to recover from many different obstacles, that's what we're dealing with in Nicaragua. So cervical cancer in Nicaragua, these are some numbers that I received from their information center on HPV and cancer that they have available, so they understand that cervical cancer is a major problem in Nicaragua. And they are reporting that the annual number of new cases is about 934 per 100,000, and that the mortality is 424 per 100,000. So that's about 6 times the death rate of what we see in the US. So 6 times more women are dying there from cervical cancer than in the United States. It is one of the most common causes of death in women, and this number is reporting as 19.4 deaths per 100,000. So this number, I apologize, is just a crude number. You can see that the cervical cancer age standardized mortality rate, which is what this is showing here. So the dark red is the worst color, and Nicaragua has that. The trends in mortality, a lot of times they report female cancers together in some countries. So this is a mortality trends graph of breast cancer and cervical cancer. So cervical cancer is this dark line up here. And so we can see from 2000 to 2009, we have kind of been declining a little bit, but not really enough, and I don't know that that's statistically significant on the decline. Screening in Nicaragua, so they have estimated coverage of cervical cancer screening and by age and what questions were asked. So we want people to get pap smears, right, so that they don't progress into cervical cancer. But we have to understand what's going on and whether or not people are being screened. So the question here is estimated cervical cancer screening coverage, and this is if they were ever screened. So we see pretty high numbers here in the 80s or so. And we replicated this number as well. So about 80% of women have been screened at one point. So they have received a pap smear once, at least. The next graph over here is showing women who were screened every year. So we drop about down to 25% in the oldest age group of women, 45 to 50 years old, but the highest percentage is about 37% in 30 to 34-year-old women. So women who are screened every year is a much smaller number. Now I mentioned earlier that in the US, we recommend screening every 3 years. In Nicaragua, they recommend screening every year because of the prevalence of cervical cancer and the high mortality rates. Additionally, there's some issues with screening and some difficulties with screening that I'll mention, and so that's part of why they recommend it every year. So just looking at this picture alone, you can see that there's a major issue between whether you've ever been screened and whether you follow up with that yearly recommendation. So we did a little bit of a research project in Ciudad San Vino when we were there. This is the name of the community that we worked with, and we worked in one neighborhood called Nueva Vida. So I might flip back and forth between Nueva Vida and Ciudad San Vino. They kind of use them interchangeably. It was a descriptive study, so we basically just were able to calculate some numbers and give them some percentages. So we didn't do a lot of higher level hypothesis testing or analytical study. But the point of that was because we work with a partner organization there called the Center for Development Central America. And they're a group of people that are actually originally from North and South Carolina that were building domestic violence shelters here, emergency preparedness shelters here, and moved to Ciudad San Vino in 1993 after Hurricane Mitch hit Nicaragua and there was a disaster response needed. They set up a clinic in that area, and that was that was the main area that we worked in. So the partner organization, we were We requested to come, we were invited to come, and we went. And they had this project that they really needed us to work on. They had public health volunteers previously, but they had not had a group of public health volunteers that really understood survey methodology and how to gather data correctly and then how to provide that data back to the organization. It also never had graduate students in public health. They had an identified health problem. I've set the stage for that so you guys can see that cervical cancer is a very much identified health problem there. They had low screening and treatment rates and high mortality rates, even in their community. They had a new program, so they had a new pap smear program that they were trying to implement. We kind of jokingly called it Pap Smear Tuesdays because the clinic was going to be open and focused on women's reproductive health on Tuesdays. They were going to have the gynecologist there to see women, and that was the priority day for women to come for that. So the clinic sees tons and tons of patients, a lot of chronic disease, a lot of infectious disease, and acute things that are going on. But they wanted to really have this be a priority day, and they wanted to implement this program and disseminate that information to their community. They were also implementing a treatment method called see and treat. So we do not do this here in the US as often because we don't see as many cases. It's also not recommended because you might disrupt the cervical cancer cells more than you are helping since it's such a slow progressing cancer. The see and treat method basically means if you are diagnosed with an abnormal pap, you go ahead and treat it as if it was cervical cancer. This has worked for them locally because you're basically going to prevent the mortality because mortality rates are so high and the healthcare system really is overburdened with a lot of things. It's easier to see and treat the woman right at that moment. We also had a lot of community engagement, so the clinic in Nueva Vida has 34 local health promoters that work in the community and work in their neighborhood. So they go out and they get medications from the clinic and they go back and they take them to people. They serve as kind of the emergency response people during the weekends when the clinic isn't open. They provide health education and they are trained by the clinic staff. So we had those health promoters that were really invested and interested in working with us as well. So just to give you an understanding of kind of where we are, and this is an old map, but this was the best one that CDCA had. So CDCA is here. This way you go to Managua, which is the capital of Nicaragua, and about 45 minutes away. And we were in Nueva Vida, so this little yellow square here. Nueva Vida was particularly set up for refugees, so all these natural disasters and unrest that I've spoken of in Nicaragua. A lot of times refugees were taken to Ciudad Sandino and then plopped in the Nueva Vida area, and as more disasters or unfortunate things occurred, another stage or another neighborhood was built. So they call stages etapas, so there were 6 or so etapas that we worked with, and then some other little communities. So this was our survey team. We had myself and 4 students in the College of Public Health went with me. We also had translators with us and then local health promoters. So a few of us spoke Spanish, several of us understood Spanish much better, but we didn't speak enough to actually administer the survey. We also didn't want to administer the survey because we weren't local, we didn't have rapport with this community, and so we were working with health promoters that did this every day with their friends basically, and family in the community. So we helped with training for how to appropriately administer the survey, and then we also helped with the data collection for us and particularly for the students, for them to get to go door to door and talk to people, even if they didn't understand every single piece of it. It was very informative. So you don't really understand if somebody's coming into a clinic and you're telling them you should get screened every year, you need to do the see and treat method, this and that and the other. If you don't understand where they live and what they're going through every day, it's very hard to tell somebody how to take care of their health. Casey and I were actually talking about this on the way over here. So you have to meet people where they're at and understand that. So for us to get to walk through the community and talk to people and see people, trying to take care of their kids and cook dinner and do everything, and then get to the clinic on a Tuesday was an interesting perspective for us. So one one of our main responsibilities was to train the health promoters and to get them to really understand how we needed to administer this survey. In previous years, they had administered a survey just trying to figure out what the denominator was of the community, so what is the population of this community who lives where. And that was difficult because of the question, how many people live here? So it was, well, they don't live here, but they sleep here. Well, they're only here certain days of the week. Or, well, he lives over there, but he also lives here sometimes. So they couldn't figure out how to ask the right questions to get the correct answer. So we could help with that. So we provided a health promoter training, and we trained 32 of the 34 promoters, and they received an hour-long training. We did this with role-playing, asking the survey questions. We had them pretend like they were going to the door and ask the survey questions. We let them know when the survey questions were asked inappropriately, what the importance was of asking the question the same way every time and documenting your responses, where to document the response, and then what the follow-up was to disseminate information about the new Pap smear program. Promoters were accompanied by volunteers, so students in the class and myself. We went door to door surveying women in each of the etapas in this community. And so if somebody wasn't home, we either passed by their house initially or their neighbor told us where to find them, so we'd go ask them. This was interesting because a lot of people, the health promoters were seen as very knowledgeable, people who cared about you, people who you would talk to. So if I went door to door here, people would not answer. Most people would also not be home during the day when we went to go do it. So we had people answer their doors, coming from, turning around from making food and saying, oh, what do you need? I'll sit with you, and pulling up chairs and having us sit and talk to them because they knew that these health promoters were here for them and were wanting to give them information. So volunteers ensured that surveys were collected properly. So a lot of times we practiced with all of the students hearing it in Spanish so that they could understand what each question was, and then we understood what the responses were. So we did kind of a crash course in this survey language that we needed to know. So if the health promoter didn't ask the question correctly, we'd nudge them and they would know what to do. So we basically figured out ways of communicating without having formal training in Spanish. And then we also had a flyer that provided information about the new program, the Tuesday program, and we told women that they needed to show up. So the survey had 4 questions on it. And for those of you guys in public health, you'll see why this is difficult for me, but because we were doing what the community wanted, we had to follow what their survey was. So questions were, have you ever had a Pap smear? So we know right now that that's a problem because we don't know when they had their last Pap smear, right? So we didn't get to ask that question even though we wanted to. So have you ever had a Pap smear? If yes, did you get your results? If you got your results, what were they? And did you receive treatment? So, and then if they answered that they hadn't received a Pap smear, there was a question asking why not. So, pretty easy, pretty straightforward, but leaves a lot of room for some limitations that I'll talk about in a minute. Over a 6-day period, over 1,000 women were surveyed. So we think that roughly the community is about 2,500 people. So we're thinking we got the majority of the women because a lot of those people are children in the community. So we're thinking that we did pretty well. The first Tuesday after this was implemented, so we started this on a Monday, and then the next day was Tuesday, so they had about 30 women lined up to get Pap smears. So we think that worked well, but we didn't track that data afterwards, so we have no way of really knowing that. This is a picture of all of us after the initial training, which was interesting to watch when you don't speak fluent Spanish, because they had quite a good time with it, and this is a picture in the clinic. So you can see that most of the health promoters are women, so this worked out well for us because we were talking about cervical cancer and we were talking about a cancer associated with a sexually transmitted infection, so we didn't want to potentially have any issues with male health promoters, although we were told that that wasn't a problem. So that was surprising for us. We were also very concerned that people wouldn't actually know what a Pap smear was, and we were surprisingly and happily, we were wrong on that. Everybody there knew what a Pap smear was because of cervical cancer being such a problem. Everybody knows what a Pap smear is. It's just, did you go get one? Did you get one in the last year? And did you actually receive your results?
Dr. Quinn, what was your sense about the knowledge of the vaccine?
So no knowledge of the vaccine. It is not something, so knowledge within the health promoters somewhat, and definitely knowledge within the clinic staff, but locally just everyday people in the community, no knowledge of the vaccine. And it's not available there currently, so it's not being promoted since they couldn't actually provide it to anyone. But I think they would have similar problems that we do kind of in this region with uptake of the vaccine.
Well, and I'm wondering, we found, of course, the presence of vaccine resistance in this area. And I'm wondering if you see any indication whether, comparing it to other parallel cases, if there might be vaccine resistance when the vaccine does make its way into the community.
I think there will be, yeah. I don't think very
for the same reasons of concerns of side effects and morality. And
I think some of morality mainly. It's very religious area, very Catholic. So I think that'll be the major issue is whether or not it's looked at as promoting sex among teenagers. Similar problem that we see in the U.S. I guess. So I'm going to move along quickly so we have a little bit of time for questions. This is just a picture of us doing, administering or conducting the survey, I guess. So you can see a few of our students in the college are here with a health promoter and going door to door. So these are similar to what we walked around in each day and the kind of houses that we see. The health promoters joked with us that I said, what if somebody doesn't come to the door, or what if they don't want to answer? And what they would do is they would just knock louder and yell louder, and people would show up at the door. So we found that also very interesting, and we had a lot of conversations that occurred just like this picture with somebody just right over the door. Luckily, quick survey, so we weren't really bothering people too much, but met a lot of people who said, well, why are you doing this, and what can we do to help, and what do we need to do? So a lot of the health promoters had personal relationships with these people because they are doing this work on different health topics all the time. So they were able to say, okay, we finished the survey, but you told me you've never had a pap smear, so you need to go on Tuesday, and if you don't go on Tuesday, I'm going to come to your house and take you on Tuesday. So that was very different for us, because if I told one of my friends that, they probably would say, I don't think you need to tell me what to do when I go and get my health care. So these are some of the results that we found. So we had a number of women surveyed by each etapa, so each stage. So this red area here is stage 2, which was also one of the bigger areas. But we wanted to kind of give back to the organization a profile of how many people were surveyed, how many women were surveyed in each area, so that they could have they could know which areas they maybe wanted to target if they were going to go into one of those specific stages. The age distribution, so of women surveyed. So we had the majority of our women were between 18 and 39, so over half of them. And then the next largest group was 40 to 49. We specifically only were wanting to ask people over the age of 18 because of just we couldn't ask for consent or anything like that, and the clinic can't really see patients under 18 unless their parent is with them, so we only asked a few 14 to 17-year-olds by accident. However, we did recommend later that they try and figure out a way to ask teenagers, because teenagers there are sexually active, so it would be good to know if they had ever had a pap smear. So this graph is showing us whether or not you've ever had a pap smear. This over here is listed by etapa or area, so there were 3 other more rural areas that we went to. The red line is yes, and the blue is no. So most people have had a pap smear, which was surprising to us. So about 80% of the women have had a pap smear at some point. So this doesn't mean that they are current with that. But we were wanting to also provide them with a little bit of information. There are certain etapas that maybe could be focused on to increase pap smear uptake. So maybe etapa 2, which had 82 women had not been screened out of the total, which was right around 300. Or maybe etapa 4, which had 44 women who had never been screened. This is a breakdown of age and whether or not they'd ever had a pap smear. So again, most of our numbers were right around 80%. The lower numbers were seen in the 18 to 22-year-olds, so they were only about 70%, and then of course women 70 plus. They did not kind of stop their screenings at 65 like we do here, so we still asked women of that age, but a lot hadn't been screened either ever or hadn't been screened recently to where they remembered, which is okay because that still is within the screening guidelines. But we were particularly kind of concerned with this 18 to 29-year-old population, which is the second bar, and then also increasing from 80% up in the other areas. The pap smear results, so we wanted to know was it a normal result, an abnormal result, or no result. So most people had in the blue line a normal result. Several had abnormal results, but almost more often than an abnormal result, you had no results. So people just didn't get their results. So they were screened, they received a pap smear, but either the lab never actually ran it, it never made it to the lab, or the woman never went back and got her results. So there's some major issues. So public labs can take months and months to actually run the pap test. Private labs are quicker, but they cost about $2. So the clinic that we work with, they're actually sends it to a private lab because they want the quicker results, because they know if they can get the woman back in to treat her, it will be better. And then, of course, it's hard to go back and get your results. So it's not like here where you're going to get a phone call that says, please call your doctor tomorrow between 10 and 12. They'd like to speak with you. The woman actually has to go back into the clinic. She has to go into the clinic, wait to see the doctor, unless you were there on the new Tuesday session, but wait to see the doctor and get your results from the doctor who's there that day. So that's somewhat difficult if a month goes by and you finally received your results and then you don't remember to go back in and get your test because nobody's calling you or emailing you or texting you, which I now can receive all of those from my healthcare providers here, but that's not happening there. So reasons for never having a pap smear was kind of interesting to us as well. So if they hadn't had a pap, remember we got to ask them if they didn't or why. Fear was a big reason. No access to the test, which was about 7%, which now they know that they do have access to the test for free. And then pain was also another reason. And then this was the green area was embarrassment. So I was embarrassed. We weren't sure how to categorize some of the other categories included. My husband or partner doesn't want me to go get it, or I don't know if I've actually had one, or I didn't want to go, things like that. So we had several limitations to this work that we did. So of course the limited questions, we recommended that they ask in the future, when was your last pap? That would be the biggest one that we would want. But also the type of follow-up for your abnormal results and where was your pap completed. So if we can know if they received their pap smear at a private clinic or a public clinic, that would be helpful because then we can know what kind of follow-up they might have had. We also had a lot of issues with some incomplete surveys, so we had to throw a few of those out. And then we also had some problems with multiple answers chosen. So if they said why they didn't have a pap smear, they might have chosen, I was fearful and I was embarrassed and I don't know. So we didn't know which one their actual response was. So some recommendations that we had at the end of this and that the students provided as part of their assignment was to increase access to pap smears, and that's currently being implemented with their program on Tuesdays, but also to really target those areas that had low pap smear uptake that you saw in the graph. Increase reporting of results to avoid distrust. So if the woman goes and gets pap smear, but then she never receives the results, it causes a lot of distrust in the healthcare system, and as we've heard, it's already kind of a distrusted healthcare system. Increased follow-up on abnormal results. So we recommended implementing a program if there were abnormal results to kind of work with some of the women locally to figure out what would be the best way to follow up with them. Also education to the community on pap smears and availability of those. That's currently being implemented as well, so the health promoters are promoting this program all the time. And then reducing barriers for HPV vaccine implementation. So once the vaccine is available, it'd be nice for people to be able to have the option to take it. So I think if you start talking about it now, it might be an option once it is available. So next steps, this is the clinic director, Josefa. So we provided her with some training on what the data was, what we were looking at, what we could do with it for her future next steps to kind of maybe an additional survey or something with a bit more depth. And then you can see here, that's Carter Florence carrying the test to make sure that they go to the lab. So being able to come up with some more efficient processes for making sure the tests are actually completed and the results are disseminated. Other next steps would be that we are going on the course again in May, and we will be following up on this program as well as assisting, from what I just heard last week, with another survey on type 2 diabetes. So to wrap up, and sorry for being over, but acknowledgements would be the epidemiology 5700 class. So Caitlin Johnkine, Carter Florence, and then Beth O'Connell also assisted with the course. So a lot of the work that was completed was part of their efforts. The Center for Development in Central America for kind of allowing us to take a chance on something that they hadn't had a lot of success with. International programs in the Honors College who help support this, and then of course the College of Public Health and my department, Biostats and Epi for promoting a course that is a little different than some of the other ones we teach. So I've listed some resources here just because I'm going to share these slides with Phyllis. So if you have questions on any of this information or you kind of want to look at any of the data that I've shown you, there's links to all of the sites that I used. So questions? Great, I explained it well.
Actually, you know I have one. No, I'm sorry, I'm trying to control myself. No, I'm curious about the state of research, what you're seeing cross-culturally, globally, in terms of prevention with male condom, female condom. Mm-hmm. I know that especially there's some question about how effective, especially with viral shedding, and so I'm just curious about what you have seen in terms of the effectiveness as a prevention.
Right. So condom use in general is a bit hard to talk about in certain settings. It's not always what people want to hear about. It's also sometimes not a woman's choice as to whether or not a condom is used. And then, in my experience, most places people haven't heard of female condoms. Sure. Either that, or they're not available, or just hasn't been around. In this community that we worked in, we asked just anecdotally, like, are condoms available? Do people use them? What's the, how does that conversation kind of go? And it wasn't really discussed. It wasn't really something that people use a lot for either pregnancy prevention or sexually transmitted infection prevention. So I think that would be a great way to kind of promote the prevention aspect of it. But I don't really think people fully understand the role of HPV, the fact that it's sexually transmitted, and the fact that it causes cervical cancer. So I think there's a lot of missing gaps within the education part. I think that's true here as well. So I think just general things like what we're doing this week are always good to kind of increase the knowledge and understanding that there are ways for prevention and there are ways for positive sexual health that can prevent really negative outcomes here. So, yeah.
So I wanted to know, have you heard how confident you would be about the reporting in of the cause of death in the death certificate in Nicaragua?
Good question. So the question was, how confident are we with the actual code that was given in the death certificate? So did the person actually die from cervical cancer? And if so, was the correct number put on the death certificate in Nicaragua? I didn't hear too much about that, which made me think I wouldn't be that confident in that number. So I think a lot of even the numbers we see here could be underreported or overreported, depending. Since it is such a problem there, it might be very easy to say, oh, a woman died and this was going on and that was going on. It was probably cervical cancer, because we see that all the time. Or a woman passed away and natural causes. So I have not heard much personally about that, but based on kind of the fact that Nicaragua is almost a new country within the past, 20, 30 years, I don't know that the health system is fully and completely functional. So it did not seem like that. We toured several hospitals and kind of health department areas, and certain programs are doing very, very well. And depending on kind of what area you are in, the closer we got to Managua, of course, the nicer things kind of started to get. The farther out and more rural you are, the more difficult it is. So I would not say that I'm extremely confident in it, but I think it's probably a bit better reporting than maybe some other places. But Nicaragua is the second poorest country in the Western Hemisphere, so it's right behind Haiti. So there's a lot going on. Yeah.
So, Mrs. Nolan had a question. Which she had to leave to get to Greenville and back by 3. What collection method were they using in Nicaragua? Did they use a liquid-based cytology, or were they using slides?
Good question. I believe that they were using slides, but we did not go into that with them. So I don't think they were using, because liquid-based cytology is, I think, a better method, and I believe they were using slides.
Okay, thank you.
But I can ask for her to get a confirmed answer on that. We didn't get to that as much as just why are the tests not going to the lab. So, but yeah. Yeah.
So would that be something that you would talk to them about and try to change, or is it for cultural reasons or some other reasons? Would that be something that you would not?
The type of test?
The type of test.
I don't think that would be an issue culturally, because I think that kind of happens behind the scenes in the lab. So I think it's more accessibility and cost. So do you have somebody that can run that test? Somebody who's been trained well enough to run it, and then also how expensive is it? So the clinic that we work with might be using the liquid cytology because they are using private labs. So that might be why that's a little bit more expensive. But I didn't ask that specific question. Yeah, Katie.
Is this a continuous project where you might go back again and do more surveys or education?
Yeah, so we continue to work with CDCA, our Center for Development in Central America, and they are hosting us again in May. So we will be going, actually a couple of you guys over here, we'll be going in May to work with them again. So now we won't do the exact same survey because we already have the information that we need right now, but I know that they want us to use similar methods to kind of help them determine some type 2 diabetes prevalence rates this May, but we'll also be continuing up with some of the cervical cancer work, probably doing a bit more of this health education piece and understanding what exactly is going on. That'll be a lot harder to measure, yeah, so it's an ongoing relationship that we have with them. College of Public Health sent a doc student there for her field placement, so she was there for 2 months the summer before last, so in 2013, I believe. And when she came back, she reported back saying, you have to take a group of students. They have everything set up very well. They've been working in the community for 20 years. This would be a great way for our students to get global health experience. And the CDCA is ready to start doing research. So that's the other purpose of this, is for us to be able to use our skills and knowledge to help them, and then also for them to kind of help us to learn how to work with global populations.
I have 2 questions.
Great.
Excuse me. Did they do education on birth control there, or offer, and did they do HIV testing, since those are pretty high prevalent in this country?
So HIV testing is available at the clinic. I don't know how many people take that option. but it is available at the clinic, and again, would be sent off to a lab. So I'm not certain exact specifics on that. HIV is prevalent there, definitely. So people are aware that there's a test available. I don't know how much it's talked about. Again, somewhat of a conservative community. So birth control also available. Depo-Provera is their kind of method because it's the shot. They can go and get the shot, and then everything's working, and they come back in 3 or 6 months, I think. And so, but I did not hear a lot of talk of a lot of women taking the opportunity to have birth control. So the community is fairly conservative, mainly Catholic, and so birth control is not widely used. So I think increasing even just awareness of what options are available, and that's kind of our goal with this. Like, you can get a pap smear, it is available, it is free. So you can get an HIV test, it's available, it's free. Same with birth control. So they have, the government, it's government subsidized healthcare system. And then also condoms, are they available? Are they affordable? And then do we know how to use them? Can we have the conversation to use them? And then same with the birth control and HIV tests. So.
I just wondered that probably would be more over diabetes, but diabetes is a chronic illness. Is there a lot of overweight?
Yeah, so if we had our say in it, totally, which we do have our say in parts of it. So like the students will get to kind of tell me what they're interested in, and we'll make sure they get to do some of that stuff. So if one in particular person picks HIV or birth control, then we would have some sort of like micro project on that. But whatever our big thing is chosen by the clinic. The reason why they pick type 2 diabetes is because they see it in the clinic all the time. So they have a whole chronic disease or chronic patient group who come in, kind of like Pastor Tuesday, they come in on Thursday and they do all these different sort of health education talks that are general chronic disease talks. But they see a lot of type 2 diabetes that has progressed fairly quickly, so they're seeing a lot of wound care issues associated with it, eyesight issues, potential amputations, foot issues. So.
I'm sure they've done needs assessment, don't they?
Yes, they have. I don't know how recently they have. So some of this is a bit anecdotal for me based on what it is. You're right. I think I broke it. But yeah, so they have done a needs assessment previously, but I don't know when the most recent year was for it. So, and whether or not this is more kind of community-based participatory research associated versus actual community needs assessment, if that makes sense.
Is there a lot of human trafficking or sex trafficking there? Or is that a problem there?
I assume it is a problem because it is a problem everywhere. Right. But I didn't hear too much about that. So now when we were over there, this was when a lot of the children from Honduras and El Salvador were migrating up through Mexico and crossing the borders. And Nicaragua did not have a problem with that. And a lot of that is kind of the family unit, family structure in the area. So there were no homeless people. If somebody is, having trouble with homelessness, they are taken in by a family member. The only homeless person you might see is somebody who everybody in their family has kind of, alienated them. But so we didn't see a lot of those types of issues because of kind of the way the family unit is. So it's very collective. So you're so-and-so's cousin, okay, come on. So I think it seems as though people watch out for each other a little bit within their local community. So I'm sure that sex trafficking is a problem, but I didn't hear much about it. And I was surprised that none of the, that Nicaragua hadn't had any of the issues with the children migrating as well.
I think we can see from the questions and the interest in your talk that we need to have part 2 of this.
Yeah.
Indeed. Well, indeed, I thank you so much for your work, Dr. Quinn, and your talk today, and thank y'all for being here.
Thank you.